Hello. So this is a recording in Fundamentals of Nursing, and it is focusing on meeting patients' respiratory needs. Okay. So the topic itself is long. It covers a lot of aspects, but for the sake of this recording, I will focus more on key areas that might be difficult for students to understand so that this recording can serve as a guide. So we know that oxygen is essential to sustain life, and for the body to receive oxygen, we need a good functioning cardiovascular system as well as respiratory system. Now, blood is oxygenated, as we know, through mechanisms of ventilation in the lungs, then perfusion and transport of respiratory gases. And any condition that affects the respiratory system as well as the cardiovascular system, which transports these gases, will result in impaired oxygenation. So as nurses, we need to be knowledgeable on how to meet patients' respiratory needs. So I will not take you through the review of the respiratory physiology because these are aspects that are covered quite comprehensively in your physiology lectures. Okay. So my thrust will begin from factors affecting oxygenation. So what are those factors that affect oxygenation? We're going to categorize these into factors that are associated with decreased, those factors that are associated with decreased oxygen carrying capacity. Okay, let's do this. So we have these factors that are associated with decreased oxygen carrying capacity. And then there are other factors that have to do with decreased inspired oxygen concentration. Okay, we'll look at factors that deal with that are due to increased metabolic rates. And then we'll also look at factors affecting the chest wall. So let's begin with those physiological factors. So what are the physiological factors that affect oxygenation of tissues? So number one, there can be decreased oxygen carrying capacity. Now, the oxygen in the body is transported bound to hemoglobin. So hemoglobin is the one that carries the majority of oxygen to tissues. So a decrease in oxygen carrying capacity can occur due to the following. Number one, anemia. When there's a lower than normal hemoglobin level, this will lead to decreased amount of hemoglobin. Okay, I mean the lower than normal levels of hemoglobin can be due to decreased hemoglobin production, as might be the case in aplastic anemia, or increased red blood cell destruction, as can be the case in sickle cell anemia, also in various infections, but also due to blood loss, as may be the case in trauma. So any of these conditions will will cause anemia and hence reduce the oxygen carrying capacity of blood. Reduction in oxygen carrying capacity of blood can also be due to inhalation of toxic substances, for example, carbon monoxide. Now, carbon monoxide reduces the amount of hemoglobin that is available to transport oxygen. Why? Because this carbon monoxide, it binds very strongly to hemoglobin. It actually has a higher affinity for hemoglobin than oxygen. What this means is that the carbon dioxide that the patient has breathed in is going to bind to most of the hemoglobin sites that are available. Remember, hemoglobin is a tetramer. It has 4 binding sites. And so the carbon monoxide will occupy those binding sites and oxygen will not be able to bind there. So its the transportation of oxygen will be impaired. So in carbon monoxide toxicity, hemoglobin strongly binds with the carbon monoxide, creating a functional anemia. Hemoglobin is there except it is saturated with carbon monoxide. Okay, reduction in oxygen carrying capacity can also be due to hypovolemia. So conditions such as shock, severe dehydration cause intracellular fluid loss and reduced circulating blood volume, or hypovolemia that will reduce the oxygen carrying capacity of the blood. Also, a decrease in inspired oxygen concentration. This is an independent factor. When there's a decrease in inspired oxygen concentration, this will result in a decrease in the oxygen carrying capacity of blood. For example, where we have a reduction in the amount of oxygen within the environment, then even the amount of oxygen that will be supplied to the blood will reduce. Decreases in the fraction of inspired oxygen concentration may be caused by, number one, a upper or lower airway obstruction, which will limit the delivery of inspired oxygen to the alveoli. For example, when a patient has a tumor that is affecting the upper airway, or maybe there's trauma and there are secretions that have accumulated in the upper airway, then there will be a reduction in the amount of inspired oxygen. Also, decreased environmental oxygen. I talked about this, for example, at high altitudes. The higher you go, the lower the oxygen tension in the atmosphere, in the environment. Hypoventilation, for example, due to drug overdose, but also hypoventilation may occur in conditions where there's trauma to the chest wall. Okay, an individual is unable to breathe in and out adequately due to that pain. That may also lead to a reduction in the concentration of inspired oxygen. Okay, other conditions, we're still looking at physiological conditions. Increased metabolic rate. Now, metabolic rate might increase in certain cases. So whenever there is an increased metabolic rate, that will increase the demand for oxygen, and the level of oxygenation declines when body systems are unable to meet this demand. So, for example, increased metabolic rate, that's supposed to be rate, is normal in pregnancy, wound healing, and exercise, because the body is using energy for building tissues. So other conditions that may lead to problems with metabolism, where the metabolic rate increases, thus increasing the demand for oxygen, because remember, tissues will use oxygen for their metabolism. So when there's an increased metabolic demand, then the body requires more oxygen. If we don't increase the supply of oxygen in a patient whose metabolic demand is high, then they'll go into a decreased oxygen supply to the tissues. So fever increases the need for tissue oxygenation. As a result, carbon dioxide production increases when patients have fever. So when fever persists, metabolic rate remains high, and the body begins to break down protein stores from muscles, and that will lead to muscle wasting and decreased muscle mass, including respiratory muscles, because the body is breaking down the muscles now to try and produce energy. So they'll become weak. Muscles such as the diaphragm and intercostal muscles will become weak. This will further impair ventilation. That is why fever needs to be treated adequately. So the body attempts to adapt to the increased carbon dioxide levels by increasing rate and depth of respiration. Whenever there's a demand, an increased demand for oxygen, and when the levels of carbon dioxide in the body have increased, you will notice that an individual will breathe more deeply and the rate of respirations will be fast. They'll have tachypnea. So patients with pulmonary diseases are at greater risk for hypoxemia, pulmonary diseases such as asthma, emphysema, tuberculosis, all those may easily develop hypoxia. So another set of conditions that can affect oxygenation include any condition, any factor affecting chest wall movement. So any condition reducing chest wall movement results in decreased ventilation. The taking in and out of air will reduce if the chest wall is not able to move adequately. So if the diaphragm does not fully descend with breathing in, the volume of inspired air will do what? It will decrease, delivering less oxygen to the alveoli and tissues. For example, in pregnancy, you will realize that as the fetus grows during pregnancy, the enlarging uterus will begin to push the abdominal contents upwards against the diaphragm. So that will reduce the distance within which the diaphragm can actually descend. Also, obesity. Patients who are morbidly obese have reduced lung volumes from the heavy lower thorax and abdomen, particularly when in recumbent or supine position. When they are sleeping, they are lying on their back. There's a lot of pressure from the fat on the abdomen. So that pressure will compress or will push the diaphragm upwards, so the lung volumes will reduce. These patients who are morbidly obese would usually suffer from obstructive sleep apnea. Other conditions that will affect the chest wall and thus impair oxygenation include musculoskeletal abnormalities. So the thoracic region musculoskeletal impairments that may result from abnormal structural configurations. Maybe, for example, there's a condition we call pectus excavatum, where the sternum is pushed inwards. Okay, that will reduce the lung volume. Conditions where there is trauma, as well as musculoskeletal diseases like myasthenia gravis, for example, diseases of the central nervous system as well will reduce oxygenation, because these muscular diseases reduce the function of respiratory muscles, such as the intercostal muscles. So a patient will not be able to take in adequate air. So I've talked about problems such as pectus excavatum, where the sternum is pushed inwards, thus compressing the lungs and even the heart, reducing the lung volumes. There are also vertebral column abnormalities such as kyphosis, a forward swaying of the spine, where there is an exaggerated thoracic curvature. Also in lordosis, where there's a backward swaying of the spine. As you may see, for example, in pregnancy, there's an exaggerated lumbar curvature, or scoliosis, which is a lateral deviation of the spine. All these might affect thoracic diameter and thus impair intake and output of air. Trauma, a condition in which multiple rib fractures cause instability of part of the chest wall. The unstable chest wall allows the lung underlying that area, okay, to contract on inspiration and bulge on expiration, resulting in hypoxia. This is what you see in flail chests. Neuromuscular diseases, okay? Neuromuscular diseases, like I mentioned, they decrease the patient's ability to expand and contract the chest, so ventilation will be impaired. This will result in atelectasis, which is lung collapse, hypercapnia, which is an increase in the levels of carbon dioxide, and hypoxia, which is a decrease in, hypoxemia, which is decreased amount of oxygen in the blood. Conditions such as myasthenia gravis, Guillain-Barré syndrome, and poliomyelitis affect the muscles. So the muscles of respiration, including the diaphragm, become weak. That will impair respirations. Then central nervous system alterations, okay? Diseases that affect the central nervous system, or trauma to the brain, for example, trauma to the medulla, okay? Trauma to the spinal cord can result in impaired respirations. Why? When the medulla oblongata is affected, neuroregulation of respiration will be impaired. And so an abnormal breathing pattern will develop, because the medulla contains the respiratory center, which helps to regulate the rate and rhythm and even depth of respiration. So when there's damage or injury to the medulla, then the pattern of respiration will be altered. Cervical trauma as well, especially C3 to C5, when any of these spinal vertebrae, the vertebra from cervical vertebrae number 3 to cervical vertebrae number 5, when these are damaged, you end up with paralysis of the phrenic nerve, and it is the phrenic nerve that supplies the diaphragm. So when there's injury to the spine at the level of the neck, at the level of C3 to C5, the diaphragm will not be able to descend properly, and that will reduce inspiratory lung volumes, causing hypoxia. Spinal cord trauma below the 5th cervical vertebra, this damages nerves that innervates the intercostal muscles. So if the nerves supplying the intercostal muscles are damaged, then there will be improper anterior posterior chest wall expansion, because the intercostal muscles are responsible for chest wall expansion. When they contract, they pull the ribs outwards and upwards so that air can go into the chest, into the lungs. Age is another factor that can affect the ability to ventilate, to take in and out air. So older adults may exhibit a barrel chest and require increased effort to expand the lungs. And also in older age, there is loss of alveolar gas exchange that accompanies or that happens as one grows old, causes a decrease in the partial pressure of oxygen. So older adults are also more susceptible to respiratory infections because of decreased activity of cilia, which is found in the respiratory tract. And you know that cilia has what we call the mucociliary escalator mechanism, where the cilia that is found in the respiratory tract keeps wafting. And as it is wafting, it moves the mucus, it moves particles and other foreign particles that have gone into the respiratory tract, moves them upwards towards the mouth so that they can be expectorated. So in old age, that mechanism becomes impaired. So these patients are more susceptible to respiratory tract infections. There are also environmental and lifestyle factors that can affect the respiratory function. So clients who are exposed to dust, animal dander, asbestos, or toxic chemicals in the home or workplace are at a greater risk of alterations in oxygenation. So individuals who experience significant physical or emotional stress, or who are obese or underweight, are also subject to changes in oxygen status. Okay. Then also, exercise is another factor that affects oxygenation. Okay, exercise. Okay, so we are talking about environmental and lifestyle factors. We have said those that are exposed to all these allergens. Some people will react to dust. They'll react to animal dander. When they're exposed to this, there will be irritation of the mucosa of the respiratory tract that will lead to increased secretion of mucus and even bronchoconstriction. All that will impair ventilation. Okay. Then I was just about to talk about exercise, that exercise increases the metabolic activity and also increases the demand for oxygen, because muscles are working extensively. I mean, the muscles are contracting at a greater rate. They need more oxygen. So the rate and depth of respiration will increase with exercise so that a person can inhale more oxygen and exhale more carbon dioxide. Now, people who exercise for 30 to 60 minutes daily have a greater, they have a lower pulse rate and a lower blood pressure. They also have decreased cholesterol levels and increased blood flow and greater oxygen extraction by working muscles. So these are benefits of exercise. At least 30 to 60 minutes of exercise per day will lower the pulse, it will lower the blood pressure, it will lower the amount of low density lipoproteins in the name of cholesterol, and there'll be an increase in blood flow. So those who exercise are less likely to suffer from these respiratory or to suffer from lowered oxygenation. Smoking, okay, cigarette smoking and secondhand smoke or passive smoking are associated with heart diseases. They are also it is also associated with chronic obstructive pulmonary disease and lung cancer. So smoking is bad for oxygenation. Now, the inhaled nicotine, which is found in the tobacco, causes vasoconstriction of peripheral and coronary blood vessels. Now look at this. The nicotine will cause vasoconstriction. When the peripheral blood vessels constrict, then the resistance in those vessels will increase. That will result to an increase in blood pressure. Then they also cause a vasoconstriction in the coronary blood vessels. These are the blood vessels that actually supply the myocardium of the heart. This will cause reduced blood flow to the heart, and it might lead to angina, and it might eventually lead to myocardial infarction. Okay. Then disease processes also may impair the oxygenation. So there are many diseases that may affect oxygenation. For example, obstructive pulmonary diseases such as emphysema, chronic bronchitis, okay? Restrictive pulmonary diseases, whenever there is maybe accumulation of fluids, okay? Tension pneumothorax, etc. All those conditions will be able to affect oxygenation. Also, for example, atherosclerosis, okay? Okay, so we have these disease processes. I was talking about atherosclerosis, heart failure, anemia, alterations in oxygen uptake. So for example, in atherosclerosis, you have deposition of atheromatous plaques or deposition of fats and other fibrin materials along the walls of the blood vessels. What that will lead to is it will cause narrowing of the blood vessels. And if this happens in the peripheral blood vessels, that will impair the blood flow to those organs being supplied by those blood vessels, and thus oxygenation will be impaired. There are also developmental factors that affect the delivery of oxygen or oxygenation. For infants and toddlers, these are at risk for upper respiratory tract infections because of repeated exposure to other children. They actually say that children are the natural reservoirs for most respiratory microorganisms or most respiratory pathogens. So because they go to school and get all these organisms from their colleagues, so they're at greater risk. You will actually notice that children are always sneezing, they're coughing quite frequently. It's because of that exposure. Then because they have an immature system and exposure to second-hand smoke, they easily develop respiratory problems. Then during the teething process, you will notice that children may also develop a lot of sinus problems, flu, nasal congestion. This is because as the teeth are shooting out, it may lead to an inflammatory process within the skull, and that will block the sinuses and increase the the blockage of those sinuses. As a result, these children might easily develop respiratory tract infections. What about for the school children and the adolescents? You realize that for these, they are also exposed to respiratory tract infections at school, but also they are exposed to cigarette smoke. They may inhale it passively. That will irritate the mucosa, leading to respiratory problems. Okay. So now, a few common terminologies when it comes to oxygenation and the use of oxygen in the body. So when we say aerobic, we simply mean with oxygen. Okay. When we say aerobic, this term aerobic simply means okay, it simply means with oxygen. That is why we say aerobic respiration. It means that respiration is actually utilizing oxygen. Anaerobic means without oxygenation, okay, or without oxygen rather. Anoxia means no oxygen reaching the brain. Apnea means absence or cessation of breathing. Apneustic breathing. This is prolonged gasping, inspiration, and short, inefficient expiration. Then asthmatic breathing, this is where one has difficulty mostly on expiration with an audible wheeze due to spasms of the respiratory tract and accumulation of thick viscid mucus, common in asthma. Biot's respirations. These are periods of hypopnea occurring in normal respiration, and sometimes you may see this in meningitis, periods of hypopnea, where the rate of respiration increases, then it reduces. Bradypnea, this is slow but regular breathing. It is normal during sleep because the demand for oxygen really has reduced. It may also be seen as a sign of opiate use. Opioids such as pethidine, morphine, okay, alcohol indulgence, or brain tumors. Other terms, we have Kine-Stokes respirations. Kine-Stokes respirations. So Kine-Stokes respirations, this is a gradual cycle of increased rate and depth, followed by gradual decrease, with the pattern repeating every 45 every 45 seconds to 3 minutes. So this patient will present with an episode where they have tachypnea, they have increased rate and depth of respiration, then the rate and depth of respiration begins to decrease, okay, and then again the pattern repeats. So that is what is referred to as Kine-Stokes respirations. You may see this also that the patients might have certain periods of apnea during these episodes, and you may see this in patients that have severe lung diseases, okay? And you may also see it as a sign of gasping when a patient is really in a critical state and they're about to die. Cyanosis, this is a bluish appearance of the okay. So just to share the screen. All right. So cyanosis, okay, so cyanosis is a bluish appearance of the skin and mucous membrane. It is caused by inadequate oxygenation. Dyspnea, this is difficulty in breathing. Expiration is the act of breathing out air, okay? Then hemoptysis, this is presence of blood in sputum or coughing up bloody sputum. Hemostasis, we know this is the automatic or self-regulation of man to maintain the normal state of the body, that is homeostasis. Then hypercapnia, this is high partial pressure of carbon dioxide, okay? Hypopnea, this is deep breathing with marked use of abdominal muscles or use of accessory muscles of respirations. Hyperventilation, this is increased rate and depth of breathing, while hypoventilation refers to irregular, slow, and shallow breathing. Okay, so take time to read a few more of these definitions. Hypoxia, is really a reduction in the amount of oxygen, and not necessarily a lack of oxygen, but a reduction in the amount of oxygen being supplied to the tissues. Hypoxemia, this is actually a reduction, not really a lack of, but more of a reduction in the amount of oxygen in the blood. Okay, Kussmaul's respiration. This is increased rates of respirations and increased depth. Panting, labored breathing. It is common in diabetic ketoacidosis, also in renal failure. Orthopnea, this is the ability to breathe easily only when the patient is in an upright position, meaning when they lie down, they find it difficult to breathe, but when they sit up, they're able to breathe with ease. That is orthopnea. Perfusion, this is the flow of oxygenated blood to tissues. Stridor, this is a harsh, vibrating, shrill sound produced during respiration, and it usually indicates an obstruction. So it is common that you get this during inspiration. Stridor is more prominent on inspiration than on expiration. It is a sign of upper airway obstruction. Tachypnea is increased rate of breathing. A tracheostomy, this is an opening into the trachea for the passage of air. Ventilation, this is the movement of air in and out of the lungs. Okay. So now let us look at respiratory therapy. Respiratory therapy. So the principle of respiratory therapy really is the application. You just do this, get a spotlight. Okay, so the application of pharmacological and non-pharmacological means to improve breathing and therefore gaseous exchange. The use of pharmacological and non-pharmacological means to improve breathing and therefore improve gaseous exchange. So this includes an assessment of the cause of the impaired breathing, then putting in measures to reverse the cause where possible, and then putting in measures to optimize or to ensure we maximize respiratory function. So you may take some time to consider the history. Now, because you've covered history taking separately, we'll not spend time on this one. So you can read through the notes on the nature of history that you must collect when you are suspecting a respiratory disorder. Basically, you want to just assess for risk factors. So you basically want to assess the presence of risk factors to respiratory problems, okay? For example, exposure to secondhand smoke, smoking. Has the patient got any cardiac problems that may also lead to respiratory problems? So you want to ask about physical exercise. Okay, you perform a physical examination. In the physical examination, you assess the cardiopulmonary system as well as the respiratory system using inspection, palpation, percussion, and auscultation. So in inspection, you perform a head-to-toe examination of the patient. You are looking for skin and mucus color changes. There will be cyanosis, okay? You are looking for the general appearance. Patients that have hypoxia or reduced oxygenation, they will look anxious due to activation of the sympathetic nervous system. You are looking at the level of consciousness. Severe hypoxia will alter the patient's level of consciousness. Then you want to also assess whether the patient has adequate systemic circulation, okay? When it comes to your palpation, okay, you want to check for the amount of thoracic excision. You will learn more of these techniques under adult medical nursing. So you want to see whether the chest is expanding adequately. You want to feel for thrills and heaves, which are signs of turbulent blood flow through the heart. For example, when a patient has mitral valve stenosis, you want to listen for tactile fremiters. For example, when you place your heel on the patient's chest and you ask them to say 99 or 1, 2, 3, 1, 2, 3, 4, 1, 2, 3, 4, or you ask them to say 99, 99, you'll be able to feel vibrations through the chest wall to your palm. So that is what we call tactile frequencies. In conditions where there is lung consolidation, tactile frequencies increases. In conditions where there is, for example, fluid that has accumulated in the lung, tactile frequencies will reduce, okay? In percussion, you want to percuss to get those abnormal lung sounds that may be, for example, dull sounds. Normally, when you percuss the chest, it is resonant to percussion. But you may find that if fluids have accumulated, then you get a dull sound on percussion. Then with auscultation, this one helps to identify normal and abnormal heart as well as lung sounds. What are some of the common nursing problems that you may come up with in a patient that has a respiratory problem? Ineffective airway clearance. Maybe when a patient has secretions in the airway, this will be a nursing problem. And then you can convert this to a nursing diagnosis. For example, you can say ineffective airway clearance related to accumulation of secretions in the airway as evidenced by wheezing or by stridor. Ineffective breathing pattern related to injury or trauma to the chest, evidenced by splinting of the chest during breathing and shallow respirations. Ineffective health maintenance, risk for aspiration, and all these others are some of the nursing problems that might occur due to impaired respiration or oxygenation. So in your planning phase of the nursing process, you want to select those interventions that will promote optimal oxygenation in the primary care, acute care, or restorative and continuing care setting. For example, patients with chronic obstructive pulmonary disease, oftentimes they will not be in the acute care, but you're more of restorative and continuing care or rehabilitation, where you teach them deep breathing exercises so that despite that chronic condition, they are able to maintain a good amount of oxygenation, okay? So that you can still look at the other aspects. In terms of the nursing diagnosis, you may make nursing diagnosis based on any of those problems that I presented earlier. The expected outcomes, really, some of them could include patient will be able to effectively clear secretions by discharge. Okay, patient will increase oral hydration within 48 hours. Remember that hydration is important in respiratory problems because it helps to soften secretions and helps the patient to expectorate those secretions, but also hydration helps to rehydrate the patient, because with hypopnea, when the patient is breathing heavily, we lose a lot of fluids by perspiration. Through the breath, fluids are being lost, so those fluids have to be replaced. Interventions might include ongoing assessment. You keep assessing the respiratory status of the patient, okay, and then you provide deep breathing therapy and exercise, as well as posterior drainage. So let us quickly look at the assessment of the airway under the interventions. Here is a problem with a a patient rather with a respiratory problem. How do we assess the airway? So you want to assess whether the airway is actually patent. This is a priority in patient's assessment. So any patient identified as having inadequate air requires immediate intervention. An inadequate airway would lead to asphyxia that may progress to cerebral hypoxia, brain damage, and finally death. So what do we do? In emergency circumstances, the assessment should be done with on the patient in the position in which you find them, okay? If the patient is lying, folded, etc., you begin assessing the respiratory function just in that same position in which you find the patient. Then your assessment should be planned as follows. You check, look, listen, feel. What do you check for? You check for responsiveness. Is the patient responsive? Are they conscious? Call them out. Hello, sir. Hello, ma'am. Hello, can you hear me? You're checking for responsiveness. Examine the chest movements and feeling for airflow from the mouth or the nose. Look at the chest. Is it rising and falling to show that the patient is breathing? Get your hands near the mouth of the patient. Feel for is there air being pushed from the nostrils of this patient to ascertain whether the patient is actually breathing. Look for altered levels of consciousness, agitation. When people are when a human being is hypoxic, they become agitated. Are they using accessory muscles of respirations? For example, you see nasal flaring, you see the sternocleidomastoid muscles are contracting just for this patient to breathe. Okay, is there asymmetrical rise and fall of the chest where some portions of the chest are moving more than the others? Agitation, like I said, usually suggests hypoxia. The listen is where you listen to patient attempting to talk but failing to do so. Are there any abnormal sounds that you can get from the patient? For example, snoring, gargling, inspiratory stridor, wheezing. That is part of listening. So when you see this patient, you approach this patient, you look, listen, and feel. Okay. All right. So when it comes to feeling, you want to feel for a deviated trachea, or you want to feel for subcutaneous emphysema. When you palpate the chest, you are feeling for crepitations under your hands as you palpate. Those might be a sign of air accumulating under the skin, which we call subcutaneous emphysema. Okay. Then tracheal deviation, the trachea should be centrally located in an individual. If there is any problem, for example, there is a lot of air, there's maybe a tension pneumothorax on the right side of the chest, that excessive air will push the trachea to the left side of the chest. So you must be able to ascertain such. All patients with trauma should be suspected to have an altered or compromised airway until it is ruled out. Okay, so if the patient is well oxygenated and is reasonably stable, this patient may not need to be intubated in the next 3 minutes. Then a methodical stepwise plan to assess for difficult airway should be made. But then how do we maintain a clear airway? We've assessed and we found that there's a problem with the airway. So let's start with basic airway management. So the approach to the patient is a need of airway access, so that you can, firstly, you want to relieve any possible obstruction. So since the tongue is the most common cause of airway obstruction, you want to relieve the tongue by attempting what we call the head tilt and chin lift, or performing a jaw thrust. This decreases the amount of soft tissue that is obstructing the airway. Then the patient might require supplemental oxygen to be given after you have performed a head tilt and chin lift or a jaw thrust. Let's begin with the head tilt and chin lift maneuver. Okay, so I'll just go to the diagram. You can read through the notes. So the head tilt and chin lift maneuver, as you see this patient here, what is happening is this. Okay, let us do this. This area here has a lot of soft tissue. So this soft tissue is compressing the airway. So what you do is you get one of your hands, place it on the patient's forehead and push downwards. Then you get your fingers onto the mentum, this hard part of the chin, not on the soft tissue because you cause obstruction, but on the mentum of the chin, and you move it in that direction, okay? So that you tilt the head or you overextend the neck. That will open the airway, okay? However, this should be avoided if there is a neck injury. If you suspect that your patient's neck is injured, do not perform the head tilt and chin lift, because it will further damage the spinal column down there, the cervical spine. And remember, injury to C3 up to C5 will impair function of the diaphragm and also mainly anyway, largely the diaphragm. And then below C5, the intercostal muscles. So in case you are not able to perform a head tilt and chin lift due to maybe a presence of a spinal injury, then you can perform what is called a jaw thrust. Let's go to the jaw thrust. So the jaw thrust is performed by you place the hands are placed on the patient's face with the middle or index fingers behind the angle of the mandible, and then the mandible is then lifted vertically upwards towards the ceiling. Okay, this is the preferred airway maneuver in suspected cervical spinal injury. This one, so you place your hand on the angle of the jaw, and then you try to move the jaw upwards like that without necessarily moving the neck. That will help to relieve the pressure of tissues on the airway. You can also use airway adjuncts to keep the tongue from falling back. So airway adjuncts are used in addition to initial airway maneuvers and suctioning in order to maintain airway patency, facilitating air, either spontaneous respirations or assisted bag ventilation. So there are two types of airway adjuncts that are available. Number one, we have oropharyngeal airways. This one is inserted into the mouth behind the tongue, preferably by depressing the tongue with the tongue depressor. Alternatively, insert upside down until it reaches the soft palate. Then you rotate it at 180 degrees, and then it rests on top of the tongue. So the airway must not push the tongue backwards. That is why we insert it upside down. Okay. It must not be used in conscious patients because of risk of gagging and aspiration. You will actually notice that if you've inserted this is an oral airway, an oropharyngeal airway, this one. Okay, so usually when inserting, we turn it upside down. This part should be up when we are inserting. Then when we reach the soft palate, that's when we rotate it to be in this position. Now, when a patient becomes conscious, they'll start pushing this out. They'll start gagging. So we use it in patients that are unconscious to keep the airway open. Another type of adjuncts, we are looking at airway adjuncts, remember? So we've talked about the oropharyngeal airway. Another type of airway adjunct is the nasopharyngeal airway, okay? So this one is inserted through the nostrils, and then it is gently passed into the oral pharynx. This tube should be well lubricated and inserted into an unobstructed nostril. If an obstruction is encountered as you are trying to insert this particular adjunct, okay, you should try the other nostril. And it is preferred in conscious patients as it causes less gagging and vomiting. If the tip is visible in the posterior nasopharynx, it may provide safe passage of a nasogastric tube in a casualty with a fractured face. Now, nasopharyngeal airway may cause epistaxis, and the use of this airway is contraindicated in patients with suspected facial fractures and basilar skull fractures because you damage the base of the skull feather as you try to insert through the nose. So this is the nasopharyngeal airway. This one, it goes through the nose into the pharynx. Another important intervention to keep the airway patent is suctioning. So this procedure is done to remove blood, liquids, and food particles from the airway. Now, some suctioning units are inadequate for removing solids such as teeth or foreign body. So the patient needs to be suctioned immediately when gagging sounds are heard with artificial ventilation. If you've connected the patient to a vent, you hear gagging sounds, immediately you should be able to suction the patient. So words of caution with suctioning the oral cavity: never suction further than you can see. Then always suction on the way out. So you pinch the tube, you pinch the suction catheter as you are inserting it. Then once you've inserted it for about 10 centimeters or so, okay, once you've inserted it by about just about 5 to 10 centimeters, Then you release the pinch. As you are withdrawing the catheter, that is when you are suctioning. Then never suction longer than 15 seconds. Then you should always oxygenate the patient before you suction. Hyper-oxygenate the patient. Put the patient on oxygen. Increase the flow. Then that is when you perform suctioning. Another important thing or easy thing that you can do, you just hold your breath. Once you've inserted the suction catheter into the patient, hold your breath so that when you feel uncomfortable because you are holding your breath, it means even the patient is becoming uncomfortable. Then you quickly withdraw the catheter. Okay. There's also what is known as the Heimlich Manoeuvre to try and keep the airway patent. So the Heimlich Manoeuvre involves an abdominal thrust. This one, we also call it abdominal thrust. So this one is used when a patient is choking or they have a foreign material that is blocking the airway. It may be applied with the patient standing, sitting on a chair, or lying flat in supine position. So supine position is only used for patients that are unconscious. Here is the Heimlich Manoeuvre. So for a patient who is choking and they are able to stand, you stand behind them, place your hand on the xiphisternum, below the xiphisternum. Your goal is to push the diaphragm upwards. So you go below the xiphisternum, and then this fist that you've clenched there is the one that is going to push inwards and upwards suddenly or briskly, so that the diaphragm is forcefully pushed upwards, and that will force air out, and that might cause the patient to cough out the foreign body. This is the Heimlich Manoeuvre with the patient lying down. You apply pressure below the xiphisternum, downwards and upwards, so that you push the diaphragm upwards briskly. That force of air might be able to push the foreign body out. Now we look at oxygen therapy. Oxygen therapy. So oxygen therapy is the administration of oxygen at concentrations greater than in ambient air with the intention of treating or preventing the symptoms and manifestations of hypoxia. Now, the process of administering, you can also say it's the process of administering humidified oxygen under pressure via mask, tent, catheter, cannula, hood, or incubator, often inside a pressurized chamber as treatment for respiratory conditions. Why should we give oxygen? What are the indications? Respiratory failure. Okay. There are two types of respiratory failure. Type 1, this is also referred to as hypoxemic respiratory failure. Hypoxemic respiratory failure. This is failure of oxygenation, failure to oxygenate the tissues. Here, the partial pressure of oxygen is less than 8 kilopascals or less than 60 millimeters of mercury, while the partial pressure of carbon dioxide is normal or low. So this patient is hypoxemic. The causes include infections, for example, pneumonia, pulmonary edema, and adult respiratory distress syndrome. Type 2 respiratory distress is also referred to as hypercapnic or raised carbon dioxide respiratory pump failure. So in here, remember that in the first one, the levels of carbon dioxide were normal, but the levels of oxygen were low. In this one, alveolar ventilation is insufficient to excrete carbon dioxide accompanied by hypoxemia. So this patient will have both low levels, they'll have low levels of oxygen, the partial pressure of oxygen is low, and the partial pressure of carbon dioxide is high. That is hypercapnic respiratory failure. It may occur with chronic obstructive pulmonary diseases, chest wall deformities, drug overdose, and chest injuries. Other conditions that may lead to respiratory failure include acute myocardial infarction, cardiac failure, shock, and also conditions in which there is a reduced ability to transport oxygen, for example, anemia, sometimes due to anesthetic drugs, and also post-operatively. These are the other conditions that can lead to respiratory failure, or where you need to administer oxygen. All these are actually indications for oxygen administration. When should we not administer oxygen? Contraindications. So there are no specific contraindications to oxygen therapy, but precautions should be taken. One, where there is increased partial pressure of oxygen, ventilatory depression may occur in spontaneously breathing patients with elevated carbon dioxide levels. What we just mean here is that when there is too much oxygen, the partial pressure of oxygen increases, it causes ventilatory depression, because the blood tends to become alkaline, and alkalinity depresses the respiratory center. So the rate and depth of respiration will reduce because there's too much oxygen. Then with high flow of fractionated inspired oxygen, absorption atelectasis, oxygen toxicity, and or depression of ciliary or leukocyte function may occur. When you give too much oxygen, you cause oxygen toxicity. Okay. Fire hazard is also increased with the presence of oxygen, and bacterial contamination is also present in nebulized systems if you're giving nebulized oxygen. So for this recording, this is where we end. There will be part 2 of the recording on the rest on oxygen delivery.